Thank you very much for the kind invitation. Thank you, Didier. And I'm going to talk about the optimal time to transplant for acute liver failure today. The background, as usual, is we're talking of the ongoing limitation of the supply of deceased donor organs, and the fact that we have a very significant waiting list mortality, particularly in Europe and in UK, which is around 10%. We've used for various transplants DCD liver transplantation, but particularly to reduce the waiting list mortality for malignancy with the greater risk of graft loss. And living donor liver transplantation has helped reducing the waiting time and dropout rates, but its use needs to be balanced really with the risks that go for the living donors. In terms of history, for liver transplantation for acute liver failure, that starts in 1983 with the National NIH Consensus Conference, where the theoretical use of liver transplantation in acute liver failure was discussed. In the mid-90s, already a few centers were established in using this technique for the treatment of acute liver failure, but the successes with acute liver failure transplants were short of those of transplantation for chronic liver disease. Now, there were concerns regarding the recovery of neurological function, and it's in Korean, and the efficacy was never tested with a randomized controlled trial. So the efficacy of liver transplantation up to today has never been tested, although the liver transplantation is now an established treatment for acute liver failure. But prognostic models for acute liver failure were developed based on 4 key determinants: etiology, the rate of progression of disease, the age of the patient, and lab markers of disease severity. Now, these models did not particularly perform well, and I'm not showing you the various models, but there was always tension between sensitivity and specificity. So if you had a lack of sensitivity, then that could have led to a failure to list a patient for liver transplant who would have subsequently died. And the lack of specificity, it's really, you would run the risk of not transplanting someone who doesn't really need the transplant and would have recovered spontaneously. This is the ELTR data. The European Liver Transplant Registry, whose custodian is René Adam, is part of the European Liver and Intestine Transplant Association. And this shows that in the 1-year survival of liver transplant for acute liver failure was again short of the success for that done for chronic liver disease. So there is something that needs to be done to improve these results, and something has already been done. Now, looking at encephalopathy, which is an integral component of the definition of acute liver failure, we know that the severity of liver injury may be apparent from the extent of coagulopathy, for example, and postponing the decision for listing for liver transplantation can be a waste of valuable time to save a patient's life. Now, this study from Elinav, published in 2005, is a prospective study on 68 patients with severe acute liver injury, not failure, defined by a derangement of clotting with INR greater than 1.7. The great majority, as you would expect, did not progress to encephalopathy and survived without liver transplant. But you could already see that with different INRs, with higher INRs, were already defining the non-survivors from the survivors. And this study showed that serum bilirubin and factor VII were better predictors of outcome than INR alone. The dissociation between isolated coagulopathy and poor outcome is most dramatically seen in paracetamol overdose, where the poor prognosis may be evident before the onset of encephalopathy. The poor prognosis is more associated with the severe refractory acidosis than with the coagulopathy itself. So refractory acidosis is the only clinical situation in the UK that where adults can be listed for liver transplantation in the absence of encephalopathy. The only other exception is for children that are less than 2 years of age. In terms of seronegative hepatitis, we know that the disease is disadvantaged by the need to demonstrate encephalopathy for listing. And this is an indolent, subtle disease where you have less severe coagulopathy, you have INRs of less than 2, for example, and it's the serum bilirubin that grows and rises, and the disease progresses up to a time where suddenly the patient will crash very rapidly and possibly die. And we know that the crash is often due to an infection that can trigger encephalopathy. So once you have infection, you're already in a worse position for transplantation. So delay in being eligible for transplant may mean poor outcomes. And we need an earlier predictor of poor outcomes in seronegative hepatitis. And one of these can be the progressive reduction in liver volume. And we know that we have almost universal death if the liver volume goes less than 1,000 milliliters. And you can see this is a typical small seronegative liver where you can have a map-like structure of areas of regeneration in green and areas of collapse, of parenchyma collapse. Now, in UK, half of the patients with acute liver failure end up being transplanted, and there is a particular situation where patients, in the UK, people try to kill themselves with paracetamol. It's also in a minor way in the US, but 10% of liver transplant in UK are for acute liver failure. For paracetamol overdose, sorry, of the all acute liver failure transplants. And waiting times influence the policy also of use of non-ideal grafts like ABO incompatible or DCD livers, for example. Now in the UK, in 98, by law, there is a restriction on the sales of paracetamol, so that this data from King's College Hospital shows that less patients have been admitted to the liver intensive care with lower INRs, and that has resulted in significantly less deaths. But also, given let's say, better presentations, and given also a huge progress in the support treatment in intensive care, the number of non-transplanted survivors for acute liver failure has constantly risen. These are the European Liver Transplant Registry data, again on ABO incompatible liver grafts, showing emergency transplantation associated with twice the rate of graft loss at 3 months. And in Europe, living donor liver transplantation for acute liver failure is not a very important part of a transplant. So it's only less than 2%, as opposed to the Far East. Data on ABO compatibility from the ELTR shows again that incompatible ABO grafts are only 5% of the transplants, but you can see in blue here, this blue line shows really much worse graft survival. In terms of the type of graft, we know that splits and reduced grafts don't perform as well, and the impact of the quality of matched graft was demonstrated by this center-based study by James Newberger, showing that more than 20% of the grafts utilized were at the increased risks, including older donor age, non-ABO compatibility and steatosis, and again, non-whole grafts. And these risk factors, when they accumulate, they cause further progressive reduction in survival. So from the King's College Hospital series, you know that risk, for example, was 4 times as great for non-whole steatotic grafts. And I remember I contributed at least to one that I had a steatotic graft and I reduced it to a left lobe, and the patient struggled, and it's almost 100% mortality we found later. In the ELTR series, looking at a subpopulation of increased risk of patients more than 50 years of age, the compounding risk was present where you had older donors, the recipient was male, and the graft was ABO incompatible. Now, in this study by McPhail, again from King's, the donor BMI greater than 35, possibly because it's a marker of steatosis, was the single most important determinant of early mortality in a series of 110 patients with acute liver failure. But the outcomes have changed over the years, and you can see that the 1-year survival rates approach 80%, both in the ELTR, particularly in the more recent times, and from the US registry databases. And also that's true for the single center experience like King's, who's got a fantastic setup in terms of liver-dedicated intensive care, where they have 86% post-transplant survival in the 5 years between 2004 and 2008. Still, the results are not as good for liver transplant for chronic liver disease, but they are better than, for example, chronic liver disease when it's at higher risk as those that start from their transplant from intensive care or are ventilated. In terms of transplant benefit, things have changed. As we've seen, the improvements in non-transplant survival for some subsets of acute liver failure, like paracetamol overdose, with improvement in survival of up to 50%, put some doubt on the transplant benefit. So we must think harder before putting patients on the list. But the lack of improvement in some other subsets, like seronegative hepatitis, is a confirmation that we need to, the transplant benefit is there for seronegative acute liver failure. Looking at poor outcomes, and I got inspiration from this beautiful review from John O'Grady on timing and benefit of liver transplantation in ALF. There are 3 large studies, one from looking at the ELTR registry again from Giacomo Germani and the late Andy Burrows, the UNOS registry, and the Will Barnell from King's, again in a single center experience. And these studies all identified ages of the recipient as a factor associated with poor outcomes, probably due to a lower physiological reserve. The BMI greater than 29 has had a similar weight as the age of the recipient in one study. And there were 3 broad indicators, one of, despite the fact the severity of acute liver failure is not, before transplant, is not predictive of outcome, but there were these 3 broad indicators. One is renal function, one is mechanical ventilation, and the other one is the use of inotropes. Now, futility is very important because the clinical condition, once you've listed a patient, can change very rapidly, and patients listed for liver transplantation for paracetamol overdose in this paper from Will Barnell again had 2.5 greater chance of dying on the waiting list compared to other etiologies of acute liver failure. And defining the point when the anticipated outcome doesn't justify anymore the use of a precious graft, it's very difficult, both from the evidence base and from the emotive point of view. And in this, again, in this review by John O'Grady, there is a bit of a stoplight with the green light for proceeding to transplant, waiting if some of the encephalopathy has not been reached or some of the prognostic criteria have not met the transplant indications, or if you are located a marginal graft, for example, you may want to wait for a better graft given the worse outcomes, and stop really for when your brain is in trouble, especially with fixed and dilated pupils, though I remember that that was never an absolute contraindication when I used to work in King's, and we transplanted several patients with fixed and dilated pupils. Invasive fungal infection, that's a absolute contraindication, and severe pancreatitis is 100% mortality really in acute liver failure. Living donors obviously has an attraction, living donor liver transplantation. This is the first report by Batsunami on a 15-year-old child with acute liver failure due to drug reaction, received a left lobe graft from his father. And the advantages is that you have a ready available graft. You don't have to wait long, particularly where in countries where you don't have a deceased donation. You get timely transplantation and excellent quality graft. But it's a small graft, and of course you can have a chance of a small for size syndrome. You can get greater recipient complications because it's a complex procedure. You can have potential donor complication, and let's not forget of the pressure that you put on the donor, particularly in a workup that it's so fast and so quick. And In terms of living donation, you have to consider it early, inform the family of the option rapidly, assess the donor. And in terms of donor safety, you don't have to take shortcuts in terms of the assessment, and you have to respect, in general, the rules for donation. This is a paper from Asan Medical Center showing equal graft and patient survival for living donor liver transplantation for acute liver failure. And this is again a paper from Asan when we looked at 110 patients. You can see hepatitis B, a big part of the etiology, and the results of living donor and deceased donors, although the deceased donors were only for being equal, but better than, obviously better than without transplantation. This is, though, the picture of the incidence of acute hepatitis A and B in the US, and with effective vaccination, the need for acute liver transplant for hepatitis B should decrease. I'm not going to go into that of neonates because it's a very particular field. And in terms of auxiliary partial liver transplantation, I have no time, although just in 1 minute I'll say that we identified in Kingsby, when I used to work there, at least Alberto Quaglia as a pathologist, the difference between diffuse injury given by paracetamol with rapid hepatocyte proliferation and the MAP-like injury with seronegative hepatitis with various hepatocellular proliferation. Patient survival, if you have a very good quality and young graft, and you have to avoid toxic liver syndrome. The results of auxiliary and non-auxiliary are equal. And this is an example of the auxiliary before reperfusion and after reperfusion. So you change the right lobe. This is the first patient I did personally, a 17-year-old with seronegative. You see a very small left lateral segment and the graft here. And this taught me really that seronegatives take their long time to regenerate, unlike paracetamol overdose. And I was almost giving up on this chap, but in August 2005, 2.5 years later, it just suddenly regenerated like that, and we were able to withdraw immunosuppression. In summary, non-transplant survival rates have improved in some cohorts of patients. We've seen prognostic models need updating, and the outcomes of acute liver failure in the last 10, 15 years have been improving. Living donor liver transplantation is a viable option for improving the timing of liver transplantation, and auxiliary transplantation can be successful in experienced centers. Thank you.